Yeah, so hi everyone. Thank you so much for joining the seminars today with Dr. Michael Jones. Just show respect to our presenter, we would mute the attendees during the presentation. So if you have any questions or anything to say during the presentation, please pop them in the chat box below and we'll attend to them during the Q&A session at the end. So this session will be recorded and published on our YouTube channel. So if you have any issues with this, please do let us know immediately. And today we have Dr. Michael Jones, who is our ophthalmologist on our panel. Dr. Jones is currently the head of the Department of Ophthalmology at the Children's Hospital at Westmead and a senior clinical lecturer with the University of Sydney. And Dr. Jones undertook subspecialty fellowship training at the Hospital for Sick Children and University of Toronto, Canada, where he received the Morin Award for the Most Outstanding Fellow. And Dr. Jones also undertook further subspecialty training in retinoblastoma with Brenda Gallie, and he has a keen interest in teaching and research and completed his Doctor of Philosophy at the University of Sydney in mitochondrial DNA and age-related maculopathy. So over to you, Dr. Jones.
Thank you very much for the introduction. So I think if you're going to be able to share the slides for me as well, Sophia, and I'll let you know when we're ready to progress.
Yeah.
That's coming up now. I think it'll be there for everyone. Great. So yeah, the topic today was solar injury and retinopathy. So we'll progress to the next slide, please. There's a few different ways this is termed, and it's something which, of course, is for, therefore, us in modern technology, as well as ancient times, a real thing. It's first actually described in ancient Greece, but we don't always just stare at eclipses anymore. We look at a lot of different technology. And I just wanted to make that bit clear. And I'm going to focus a lot on the risks for this because, of course, this is a medico-legal platform and seminar, and understanding where people come to with this injury. Of course, I'll talk about what happens and what we do to also diagnose it, and a little bit about the natural history and treatment, but to focus very much on where this comes from. So it's also known as solar retinopathy, photopic retinopathy, and eclipse retinopathy. You can understand looking at the sun, looking at bright lights, and even looking at eclipses, and the sun being a part of that as well. There's a risk factor list here, and I'll actually go through some more specific details and risk factors later in the lecture, but this is a sort of a comprehensive view of where people are likely to be at greater risk or who's likely to be at greater risk. Of course, if it's someone looking at the sun, that makes perfect sense, but we see this in occupational areas, and particularly with welding exposure, sunbathing, and in tanning, under the influence of drugs. In some religious rituals, of course, we talked about eclipses, people who might have mental disorders, the use of laser pointers, even some of the equipment we use in ophthalmic surgery. There's been reports of this happening from drone flying as well, and reflected light from water, desert, snow, and screens. So I will actually cover some of these in a little bit more detail later, but that's there for reference, and you might find patients or people come to us from any one of those different areas. So if you don't mind progressing to the next slide. Thank you. So the way to understand this, more than getting too complicated in terms of the anatomy of the eye, is really just to think of the eye as a simple camera. And it really is in very much the same sort of structure. You can see there's a lens at the front, the cornea. There's a lens in the eye called the lens, or the crystalline lens. Those two focus light on the back of the eye, and you have light focused for fixation in a very central area called the fovea, which may not be a very common term for people, but you would have almost certainly have heard of the macula in terms of macular degeneration. And that's the area, so when you're looking at something, that's the bit of your eye where you're fixing. And the photoreceptors for detailed vision, the cones, and the color photoreceptors are in that area at a very high concentration. And obviously then if you're looking at something directly and get light exposure, it can be incredibly toxic or damaging to the vision right where you need it least. And the reason there's damage too is because we have nerve tissue at the back of the eye, but very much like an old-fashioned camera where there's a film inside the camera, there's a film in the eye behind the retina called the retinal pigment epithelium. That's a light absorbing film. It makes photopigments and supports the regeneration of the chemicals for vision processing in the eye. But then that can get damaged as well. And we'll look at some OCTs or some high-powered scans of the eye, which will show this and where you can get the damage. So again, if you just think of the eye like a camera, you can imagine why shining a really bright light and having a focus like a magnifying glass on the back of the eye could damage the eye right where you need it least. So if you don't mind moving on again. Thank you. So then people will complain of what would then, I guess, be fairly obvious symptoms, which would be that they don't see as well. It's very commonly bilateral, so people may be squinting or closing one eye, but usually it's bilateral but asymmetric because of that. It's a central or paracentral scotoma, and a scotoma is a word for just a loss of vision, like a blind spot. There'll be light sensitive with it as well, and you can get metamorphosis or metamorphopsia, which is a distortion in the image. So they can see, they might be able to read a vision chart, but it's a little bit wavy or distorted. And because of the light sensitivity as well, sometimes people even complain of a headache. Now, this next point is pretty key, and it's actually to the sort of heart of the matter, that almost always you get, and I apologize, I've seen right now there's a spelling mistake. It should be spontaneous recovery, so I apologize, that's my fault. But you should see spontaneous recovery within weeks to 6 months without treatment. So it does usually get better with time. It doesn't always do that, but it can take many, many months to get better. So we've moved to the next slide, please. So the mechanisms of damage are multifactorial. And again, this isn't to sort of make it too scientifically based, but there's light damage in different ways. So photothermal, the heat damage, there's photochemical or chemical derangement or damage, and even photomechanical disruption. So if you look at the thermal side, you have these cells in the back of the eye. They're melanosomes, which are sort of like you have in skin. As you'll see, there's also another word, they're melanocytes. So they're pigment cells. They're in this area under the retina, the retinal pigment epithelium. So they're absorbing light. And then even underneath that deeper, you have melanocytes. And so they're like a lighter heat sink. And so they will take on this thermal injury. And because of that, overheating can then cause damage to the photoreceptors. And I put one point there too, which is that near infrared radiation can raise temperatures by even 10 degrees centigrade, which is a lot for biological tissue. So if we move on again, photochemical damage is the fact that you can actually damage some of the lipids or the proteins in that retinal pigment epithelium. And photomechanical is because you can get an acoustic shock wave in the retina caused by some of the lasers, so they can be disruptive. Some of the lasers we use are purely on light absorption in a particular frequency and then destruction, but some of the lasers we use actually are sort of making disruptive acoustic shocks or little plasma bubbles and popping. And so there's a photomechanical aspect to this as well with some of the solar retinopathy. So if you move on again. So the risk factors can be related to what's happening in the eye or the camera itself. Now, I've shown a picture below where you can see a brunescent or a brown cataract. And you could well imagine that if you had that in your eye, cataract acts as a filter. So having that lens blocking light would protect you from any sort of photopic or sun or light exposure damage. And so the light in terms of the UV absorption spectrum is naturally blocked by the lens, but as it ages, you become also a more neutral density filter or like a sunglass filter in effect in the eye. So aphakia means if you haven't got a lens in the eye. So if you haven't even got a lens in the eye at all, then you are at risk of having that light exposure causing toxicity. And pseudophakia is what happens when you have cataract surgery and they put an artificial lens in the eye. Now, that's important that the artificial lenses we put in eyes actually do have UV protection as well routinely since the 1980s. So it's not that having cataract surgery is a risk as well. So having cataract is protective. Having a normal lens in the eye is also protective. Not having a lens in the eye would actually put you at some sort of risk. The refractive state is important as well, because if you have an image which is like a magnifying glass focused very at a fine point, very finely on the back of the eye. So emmetropy means you don't need glasses and things are focused well on the back of the eye. Or if you're slightly far-sighted and again, the lens is focusing on the back of the eye, that can be a risk factor as well. So we'll move on to the next slide, please. It makes sense, like a camera, there's an aperture, and you know there's an aperture in the eye, which is the pupil from the iris. So if you have a dilated iris or a large pupil, then you're going to have more light coming in and more risk. The reasons that might happen could be that you might have an abnormal eye for other reasons, from trauma or damage or some congenital disorders. But even with anxiety, there's a nervous reaction for your pupil to dilate. That can happen also during exercise. And as mentioned in one of the risk factors earlier, certain drug use can also dilate the eye as well. Environment's a big thing, of course. You see the pictures in the books of the explorers where they're wearing their sunglasses in the snow, traipsing to the South Pole, and snow blindness and light blindness from reflective surfaces is a real issue, even being on boats in the water. So highly reflective surroundings typically include water, snow, sand, and glass. And even then, worse at altitude. So there's a reduced atmospheric ozone at higher altitude and greater chance of the photo exposure. Thanks. If you move on. So how do we pick it up? So if you're looking here, this is a photograph which shows what would be, in many ways, without thinking about it, an almost normal picture. You can see a disc on the side of the photo towards the left, which is the optic disc. That's the nerve that plugs into the back of the eye. There's blood vessels coming in and out through that, and they travel almost as an arcade. And right in the center of that, there's a slightly darker patch, and that's your macula. That's your center of vision. So when you're looking at something, that's the spot you look in. And in this photograph, there's a little yellow spot right in the middle of the center of your vision. And that yellow-white spot is actually then indicative of that. So if you see that as a photograph, that's one way that we might diagnose this, and documentation is also extremely important in any medical legal assessment. But this will be something which would be very acute and usually wouldn't last. So this is within the first days or week of injury. So if you move on to the next slide, please. So optical coherence tomography is something which is very commonly employed in any eye specialist practice, and including optometrists. So everyone would usually have access, and then even in regional areas, via ophthalmology or optometry, to OCT. And the level of resolution with OCT these days is quite outstanding. And you can see every single layer of the retina. In that picture, there's an arrow pointing to a black spot, which is where the pigment epithelium has been damaged by the photo exposure. And then that's showing in an area of depression where that's the center of your vision, the macula's fovea, where you're getting that very detailed vision. So if we see someone in the first few days, we get this hyperreflectivity in the fovea, and that it can involve all layers. So we can see acute damage. And then later on, you can see this focal disruption of different zones or layers from deeper down in the retina. And we can monitor them, and you can actually see how they repair and change over time. So if you go to the next slide, there's a special tool you can use with some of our cameras, which is called autofluorescence, which is a characteristic of some of the special chemicals in the cells in the back of the eye. And with autofluorescence, you can see this very well circumscribed area in the retinal pigment epithelium, like a halo. And there's a dropout and then a surrounding hyper autofluorescence. So you could see there on that picture very much more clearly than we did on the actual photograph, where there's a spot in the center which lights up to show that abnormality. So very important modes of diagnosis, and patients who are suspected of this are needing to be assessed usually with these modes, as well as having their acuity or their vision documented. So if you go to the next slide again, please. So diagnosis, we can do this in several ways, and it would make sense, of course, at starting at the bottom of that list that we just did the vision acuity. So we are usually assessing people on vision loss with a vision system impairment on visual acuity. We're also assessing them on visual field, and that's what's a scotoma, but you'd be looking at a very small area because it's usually very focused or focal damage in a small area, but we can map that with a perimeter. And there are in between, you can see a multifocal electroretinogram is a very specialized piece of equipment where we do electrophysiology on the eye, but that can also document the damage to the photoreceptors in the retina as well. So if we move on to the next slide. Now, treatment, because the natural history is usually very good, there's no typical specific therapy, and most people do report a complete recovery of vision within weeks to 6 months, as I said before. Now, there's not always going to be the same mechanism of damage, and then it's worth mentioning in particular laser pointer maculopathy, because that might just take things to another level in terms of the damage, and then also make the possibility of treatment different. And in these cases, you can cause a full thickness macular hole. There can be retinal disruption in the outer layers. You can have bleeding in the eye, and you can form a scar tissue or a membrane. Now, macular holes and membranes can be treated in terms of surgical intervention, and that might be appropriate if someone hasn't recovered and have those changes, specifically usually from laser pointer maculopathy. So if you turn the page again, now the fact is that as you see laser pointers, they're seen as a toy, and the trouble is they're very far from it. And the trouble is in particular that what you get may be not what you think you're getting. Australian studies have shown that the labeling applied to the laser products doesn't reflect the hazard appropriately very often. And the majority of laser pointers tested failed to meet the hour point restriction, which is less than 1 milliwatt, and a large number of lasers tested fell within a hazard category. Like these are lasers we use to burn and treat therapeutically in the back of the eye, like class 3 lasers. So there's a real problem because you can go online on eBay and order, and you honestly don't always know what you're getting. As well as that, some lasers aren't even infrared, they're on the UV light spectrum side, and that can be developing other changes in the eye, such as cataract. So there's essentially an issue that unless you get the laser, send it to the lab and get it tested, you really actually have no idea what was going in the eye. So there's another important point in any sort of case where if you can not just document what's happened, as I described before, and image what's happened, you should ideally try to find out what was used and have that even analyzed for that specific machine, make sure it's functioning properly, that laser pointer, etc. So if you go to the next slide, please. Treatment isn't always about leaving things alone, but I just wanted to mention this for completeness. It's not it's not so easy because really there isn't very good evidence of any treatments working. When you have inflammation in the body, in any part of tissue of the body, where you can find steroids are very powerful and potent anti-inflammatory agents, and it sort of makes sense that if something's inflamed that we give you steroids to make it better. There are some case reports with a solar retinopathy of being given steroids, and we can give steroids either orally or topically as an eye drop. We can inject steroids around the eye. We can even put steroid injections inside the eye. Sounds a little bit horrific, but it's actually something that we do in ophthalmology all the time, and really it's actually relatively very, very easy to do. But none of those have actually been shown to show a distinct benefit. So if someone had a case and wasn't treated or weren't given any of those treatments, it wouldn't be that there was any negligence or issue in the treatment, because there's no great evidence that that should have been done. And nothing's been found to be superior to conservative management. And most importantly, sticking a needle in an eye isn't always comfortable for the person and has risks. Even oral steroids have significant risks, and even topical steroids have risks developing cataract or glaucoma or pressure in the eye as well. So you've got to weigh that up, and on balance, in fact, you might even say that doing nothing was the smarter treatment in almost every case. So if we progress again, there's the end of the talk. So I've included all the references for completeness. I don't expect anyone to need to go into them. the way this is published, I had to make sure that it was all there. And as you can see from the references, there's actually an incredible amount of information to this, but I do hope that the take-home message at the end of all that is actually relatively very clear. So I'm happy to answer questions or take questions now if anyone wanted to clarify anything that I've talked about.
Thank you so much, Dr. Jones, for your presentation. It was very thorough and informative. I actually have a question from a case manager who couldn't attend this seminar. Yeah, so they just want to ask, like, I saw that you mentioned the images, but what specific documents would you require for a medical legal assessment when it comes to these cases?
Yep. So we would definitely require the visual acuity, which is the basis of where any whole person impairment or vision system impairment would come from as the sort of the most important part of this. The other documentation is almost diagnostic, and I've seen patients with these cases where they've had normal imaging post the injury but still have vision issues. But I think it's very important that you have the vision, and they should also ideally have OCT, the optical coherence tomography, and retinal photography. But they're very easily accessible technologies, and every shopping centre in the country with an optometrist will have those machines available. So I think as a minimum, it would be really important, and especially even for when there's a question of a diagnosis can mean the provisional diagnosis. We need to know that this is actually the case, and then it goes on that you would ideally also like to have a full eye exam with an optometrist or an ophthalmologist, but that's part of our assessment. But documenting visual acuity, doing an OCT and a fundus or a retinal photograph would be more than adequate. And then those other things I mentioned, like electroretinogram, are very academic. That doesn't need to be done. And even the microperimetry, we might do a visual field as part of every standard visual system impairment assessment. We check the visual field and would do that routinely. And it's important to do that. And probably I'd still add that to the list, but not microperimetry, but doing a visual field test would be ideal as well. Because a scotoma is a blind spot. And if you can see a blind spot in the middle of someone's vision, then yes, of course, that's accessible and important as well.
Thank you so much. I'm sure that would be like very informative to our clients. And just one last question is that based on your experience, how long does it take for the client to go back, like for the claimant to return to work after being diagnosed?
It's going to be very different, as you might imagine, because this is a dose-related problem, and also the pathology can be related to different mechanisms of injury. You know, someone who stared at an eclipse compared to someone who got a laser pointer in the eye. But I would actually say it's important. I tried to make that, I guess, that one statement that 6 months. Like if you were going to be looking, and I think in medical legal terms, often people's symptoms and how they feel and how they're comfortable and going back to normal roles, etc., is something which needs to be given time. And you would normally expect, I think, a reasonable time frame, and what's actually published in the literature as an expected reasonable time frame for return to full and normal duties would be up to 6 months.
Yep. No, that's all good. Thank you so much for your answers. And because there's no other questions in the chat box, I think that's all for today. So thank you so much for your presentation, Dr. Jones.
It's a real pleasure. Thank you.
I'll stop the recording now.